Very good afternoon, everyone. I hope the audio and video are clear, and I also hope the slides are getting shared. Good afternoon, everyone. This is Dr. Aparna from KIMS Cuddles Neonatal Unit. Today, we're going to discuss an approach to one of the common morbidities that we encounter in neonates, hemodynamic instability or shock. So I'll be beginning this presentation by discussing some common case scenarios in neonatal shock. We will discuss what we mean or how is shock defined. We should also discuss something about the pathophysiology of shock. We'll also be discussing the use, the indications, doses, and mechanisms of actions of some of the common vasoactive agents that we use, and the role and place for hydrocortisone in catecholamine-resistant shock. In the last 20 minutes of this lecture, we shall be going bedside, and we will be discussing some of the common clinical as well as echocardiographic parameters that we use as neonatologists to assess to identify the presence of hemodynamic instability, and also useful parameters that can help us to guide the choice of inotropes in various situations. We shall begin with the following case scenario. So this is baby of A, born at 39 weeks with a birth weight of 2,900 grams, born by prolonged normal vaginal delivery. The baby did not cry immediately after birth. There is no history of meconium-stained amniotic fluid. The baby needed extensive resuscitation in the form of positive pressure ventilation followed by endotracheal intubation. So this lasted for almost 10 to 12 minutes. The baby started having spontaneous respiration. At the end of 10 minutes, the UPCAR scores that were recorded were assigned were 3, 5, and 7 at 1, 5, and 10 minutes of life, respectively. The cord arterial blood gas revealed a pH of 6.84 with a base excess of -19, which is suggestive of severe metabolic acidosis, indicative of intrapartum hypoxia, with elevated lactate at 5 millimoles per liter. The baby required mechanical ventilation with SIMB mode with pressures of 18/5 and fractional inspired oxygen concentration of 40%. This was the first X-ray, which, as you can see, shows the presence of cardiomegaly. There is prominence of both the right heart as well as the left heart. There is presence of uniform bilateral haziness involving both the lungs, particularly the bilateral upper perihilar zones seem to be prominent, probably because of pulmonary venous hypertension or pulmonary edema. On examination at 1 hour of life, the baby was found to have tachycardia with a heart rate of 185 beats per minute, with tachypnea with respiratory rate of 65 per minute, and hypertension. The systolic blood pressure was low at 48. Diastolic blood pressure was 30 millimeters of mercury, which is just at the 5th centile, but systolic blood pressure was low. Peripheral pulses were feeble. CRT was 4 seconds. The baby did not have seizures, at least until that time. So we clearly can appreciate that this baby with tachycardia, systolic hypotension, and feeble peripheral pulses, prolonged CRT, clearly is in shock. So we get a bedside echo, which shows ejection fraction of 25%, which is just borderline low, poor myocardial contraction or LV function on eyeballing with signs of severe pulmonary arterial hypertension. So this is a case of clear-cut asphyxia with PPHM. So this case actually illustrates an example of one of the common varieties of shock that we see in newborns, which is cardiogenic shock. The contributing factors for cardiogenic shock include severe myocardial dysfunction in the form of asphyxia, sepsis leading to systemic inflammatory response syndrome, myocarditis which can follow viral infections such as Coxsackie, adenovirus, echovirus, and cardiomyopathy which can be congenitally acquired congenital cardiomyopathy due to various genetic mutations, so congenital dilated cardiomyopathy and congenital hypertrophic cardiomyopathy. The common clinical scenarios where we see cardiogenic shock include, as we have just seen, a baby who is born with perinatal asphyxia, or an infant of diabetic mother who is born with hypertrophic obstructive cardiomyopathy, where the baby can present with severely impaired diastolic function of the heart and impaired left ventricular filling. This can lead to decreased cardiac output due to the asymmetric septal hypertrophy. Sepsis often is associated with myocardial dysfunction and cardiogenic shock. And the same situation can also be seen in a baby who has had a postnatal hypoxic event, like a baby who has had a cardiac arrest post-delivery. The important clues that we get clinically are the presence of systolic blood pressure being particularly low. Like we saw in this baby, systolic blood pressure usually corresponds to myocardial function. And hence systolic BP is particularly low in cardiogenic shock. And there may be other evidence of cardiac failure in the form of hepatomegaly, in the form of cardiomegaly, both clinically and radiologically. There may be the presence of bilateral basal crepitations, and in the X-ray, we may be able to see evidence of pulmonary edema. Perihilar haziness may be present, and batwing type of appearance in the X-ray. And there can be other signs of cardiac failure like gallop rhythm in advanced cases. In arrhythmia that is preceding cardiogenic shock, particularly as seen in paroxysmal supraventricular tachycardia, or sometimes in post-op JET or junctional ectopic tachycardia, the baby can have increased heart rate, especially more than 220 per minute in a baby who is in neonatal age group is taken as abnormal and indicative of PSVT. And when we take the ECG, we can classically demonstrate absence of P waves or abnormal P waves in paroxysmal supraventricular tachycardias. So moving on to the second case scenario, baby of P. This baby is born preterm, 27 plus 2 weeks with a birth weight of 840 grams. The antenatal history revealed that the mother did not receive antenatal steroids and she delivered by a spontaneous preterm labor. Apgar scores were 7, 8, and 8 at 1, 5, and 10 minutes of life. The baby had respiratory distress requiring early CPAP with PEEP of 5 centimeters and FiO2 of 30%. And this is the first X-ray which shows bilateral white-out lung, suggestive of hyaline membrane disease. So the typical management would involve administration of the first dose of surfactant with either Ensure or the newer, less invasive modes of surfactant administration. But again, in this baby, after 1 hour of life, the baby was found to have a blood pressure of 30 by 10 millimeters of mercury. Heart rate is 135, so the baby does not have significant tachycardia, but there is hypotension. Both diastolic pressures as well as systolic pressures are low. Diastolic pressure is particularly low. Prolonged CRT, cool peripheries, the baby has respiratory distress with Silverman-Anderson score of 3 on CPAP. So again, is this baby in shock? The decision on assigning the diagnosis of shock may be a little tricky, especially in a preterm, in an extremely preterm newborn with an isolated hypotension. But in this baby, we have also been told that the baby has signs of poor peripheral perfusion. So although presence of isolated hypotension may be tolerated in some preterm newborns who have otherwise normal peripheral perfusion, normal lactates, no evidence of metabolic acidosis, and echocardiography showing good myocardial performance, in this baby, hypotension is accompanied by poor peripheral perfusion in the form of prolonged CRT and cool peripheries. So this baby definitely needs to be supported hemodynamically. So what causes shock, particularly in preterm newborns in this gestational age? The factors here are failure of the transitional circulation. Typically, shock is early in onset and is accompanied by biventricular dysfunction. There is also PPHN, secondary to respiratory distress syndrome, surfactant deficiency, and a large PDA can shunt blood, and this can complicate the systemic hypoperfusion. So the pathophysiological features include bad lungs, complicating PPHN, increased systemic afterload because of the sudden removal of the placental, low resistance placental circulation, which can increase the systemic vascular resistance suddenly and lead to LV dysfunction. And we must also remember that preterm newborns with a less compliant myocardium can also have some degree of left ventricular diastolic dysfunction. These manifest with low SVC flow or low cardiac output and also suggestive of high systemic vascular resistance. So this classically kind of goes into distributive shock, where there is abnormal vasomotor tone regulation leading to abnormal systemic vascular resistance, where excessive vasoconstriction can lead to high SVR and excessive vasodilatation can lead to decreased SVR. So peripheral vasodilatation, as can be seen in the cytokine storm phase of sepsis or associated with vasodilatory drugs or neurogenic shock, can be seen manifesting with low diastolic blood pressures. The other features in this clinical features in these conditions would include the presence of sclerema, bleeding, which are indicative of sepsis with DIC, presence of lethargy and encephalopathy, and there could be wide pulse pressure because of the decreased diastolic blood pressure. There is excessive vasoconstriction, which can explain increased systemic vascular resistance in the first 24 hours, as seen in ELBW babies, can lead to relatively higher diastolic blood pressure, but this can pose higher strain on the left ventricle, leading to left ventricular dysfunction. Moving on to the case 3. This is baby of S, born at 37 plus 4 weeks of gestational age with a birth weight of 2,900 grams, delivered by normal vaginal delivery. This baby was born at an outside hospital and was referred. There were no significant antenatal risk factors. The baby was apparently told to have cried immediately after birth. Baby presented with massive lower gastrointestinal bleeding, significant volume of fresh blood in the stool, and was looking pale. And the baby is now 3 days old. On examination, the baby has tachycardia with a heart rate of 180 per minute with feeble peripheral pulses. The blood pressure is always look at the systolic and the diastolic components of the blood pressure independently. So you can appreciate here that the blood pressure is actually within normal limits. Both systolic and diastolic seem to be above the 5th centile, but there is relative narrowing of the pulse pressure. So this could be because of the compensation that the baby is having for the initial phase of shock when the baby develops vasoconstriction. So the diastolic pressure has gone up slightly. Systolic pressure is okay. So effectively the pulse pressure has become narrow. The CRT could not be assessed because the baby was severely pale. Respiratory rate was 60, but the baby had acidotic breathing. And when we got a blood gas, the baby did have significant metabolic acidosis with pH of 6.9 and base excess of -20. So why is this baby having severe metabolic acidosis, compensated shock with tachycardia and severe lower GI bleeding? So investigations revealed that the ultrasound showed no evidence of malrotation. Abdomen X-ray showed normal gas pattern. There was no evidence of necrotizing enterocolitis. And hemoglobin was very, very less at 4 grams. The baby had severe anemia, normal platelet count, normal white cell count, no obvious evidence of infection in the blood counts. And the coagulation profile clinched the diagnosis. Both PT and APTT were abnormal, indicative of vitamin K deficiency bleeding. So this was a case of classical HDN. The baby had been managed until the reports came with the fluid bolus. 1 dose of vitamin K had already been given. And 2 units of packed cell transfusion were given in view of severe anemia. The baby also received a dose of 1 infusion of fresh frozen plasma. So the prothrombin time in APTT normalized at 24 hours of admission with a single dose of vitamin K. So proteins which are induced in vitamin K absence or PIVKA levels were sent, but these came back inconclusive. So anyway, this was a case of classical vitamin K deficiency bleeding. There was no recurrence of coagulopathy or bleeding manifestations. Hemoglobin improved to 13.4 grams by 48 hours and the baby was discharged. So this is a classical case of hypovolemic shock. This can happen in 3 scenarios, relatively less common in newborns actually. Isolated blood loss, which we can see when there is huge placental bleed as an antepartum hemorrhage, intraventricular bleed in preterm newborns, especially born with asphyxia, pulmonary hemorrhage manifesting with pallor, sudden respiratory deterioration, and DIC, disseminated intravascular coagulation. In all these conditions, there can be blood loss. Sometimes hypovolemic shock can follow massive loss of plasma, which can follow babies with hypoalbuminemia and low oncotic pressure, like a baby who is born with hydrops, non-immune or immune hydrops, where there can be low oncotic pressure due to hypoalbuminemia or fetal liver failure, cardiac failure. And there can be massive capillary leak as seen in sepsis and necrotizing enterocolitis. ECF loss occurs in extremely preterm newborns with unprotected skin or insensible water loss when they are managed in unhumidified, non-humidified environment like in a radiant former, particularly if plastic wraps, polythene wraps are not being used as well, then there can be excessive insensible water losses, particularly if things like phototherapy are also used, and this can also lead to excessive ECF loss and hypovolemia. However, pure hypovolemic shock, as we discussed, is extremely rare in newborns. So we have discussed one case each of cardiogenic shock. We saw a case of distributive shock, and then we discussed a case of hypovolemic shock. Now we move on to case scenario 4. This is baby of N, term 38 weeks, 3,500 grams, born by LSCS with Apgars of 8 and 9. So this baby had no asphyxia, no resuscitation was required, received routine care. The baby was started on early breastfeeding and was shifted to the ward and was being managed by the mother's side. At 28 hours, the baby was noted to have off-color look and cold peripheries and was shifted to the NICU. On examination, had tachypnea, respiratory rate of 65, retractions, and Silverman score of 2/10. Tachycardia with heart rate of 175 beats per minute with poorly felt pulses in the lower limb, whereas upper limb pulses were well felt. Blood pressure was 46/30 in the lower limb, and upper limb, the blood pressure was high, 86/48. CVS examination revealed a short systolic murmur with hepatomegaly. So this is a classical case of a duct-dependent systemic circulation. Classical presentation, baby deteriorating by day 2, day 3. Although this can sometimes manifest until the end of the first 28 days also, the baby having discrepancy between the blood pressure as well as the pulse volume, upper limb being higher and lower limb pulses as well as blood pressures being poorly felt. So this is the X-ray which shows cardiomegaly with evidence of pulmonary congestion, and echo showed turbulence in the descending aorta. As you can appreciate here, this is a classical case of duct-dependent congenital critical heart disease coarctation. The baby was managed initially with a fluid bolus, and a UVC was established. The baby was begun on cardiac support with dobutamine at 10 mics per kg per minute. Prostaglandin infusion was started, awaiting echo, and then the baby underwent coarctation repair. The fifth case is a preterm 31-weeker, 1,200 gram baby who was having an inline umbilical catheter on glucose infusion in view of hypoglycemia. The baby was requiring relatively high rate of glucose infusion at 12 milligram per kg per minute. The baby was on room air at around 96 hours when the baby suddenly develops pallor and prolonged capillary refill time. Central and peripheral pulses were not felt and blood pressure was not recordable. Basically, the baby developed a near cardiac arrest situation. The baby became hypoxic, low saturations, bradycardia, heart rate dipping up to 70, 80 per minute. The baby had to be begun on positive pressure ventilation and was intubated. As the heart rate dipped further to less than 60, one cycle of chest compressions were given. The baby was resuscitated with a fluid bolus and epinephrine infusion. Prostaglandin was empirically started with a suspicion of a duct-dependent heart disease. A quick bedside echo was done, which revealed a pocket of fluid around the baby's heart, just within the pericardium. And as you can appreciate here, compressing the cardiac chambers. And this is a classical case of cardiac tamponade, possibly because of the displaced tip of the umbilical venous catheter. So what are we dealing with here? This is a case of obstructive shock, either because of obstruction of at the level of the vessels, like coarctation or aortic stenosis, which can manifest with poor lower limb pulses and decreased blood pressures in the lower limb, especially around the time or after the time the duct closes. Or this can be seen in tension pneumothorax or cardiac tamponade, where the other clinical signs would include muffled heart sounds. In tension pneumothorax, we may see hyperexpanded chest and unequal air entry, decreased air entry on the side of the pneumothorax. And in blood gases, we will see carbon dioxide retention. There can be acute cardiovascular collapse like we saw in this case. So this is a case of obstructive shock. Now, moving next to the last case scenarios before we discuss the topic. Day 7 term baby, 2.9 kg birth weight, female. The baby manifested with poor feeding of 8 hours duration. After discharge, the baby has come back to the hospital with these complaints. Poor feeding for 8 hours. The baby is drowsy. On examination, the CRT is prolonged. Baby is cold, tachycardic, hypotensive with blood pressure below 5th centile. There is no abnormality on cardiovascular examination. There is no organomegaly. The baby is taken into the radiant warmer, rewarmed, started on nasal cannula oxygen, and the baby is resuscitated with one fluid bolus followed by a central line insertion with dopamine and epinephrine in the doses indicated. Now, on physical examination, the baby actually had classical evidence of ambiguous genitalia. So this is a female baby, as we saw in the case scenario, but the baby you can appreciate has clitoris hypertrophy or enlargement. There is also hyperpigmentation of the external genitalia, and there is fusion of the labial folds. So this is a case of DST, or disorder of sexual differentiation. So further evaluation is required, but considering that CAH of 21 alpha hydroxylase enzyme deficiency is the commonest type of type that presents in this manner, especially with shock in a female baby. The baby is started on appropriate management after sending the lab tests. Lab investigations revealed normal counts, hyponatremia and hyperkalemia. Sodium is 115, potassium 6.7 with the normal serum creatinine. So in any baby presenting to us with a postnatal collapse, think of a duct-dependent CHD or an inborn error of metabolism or congenital adrenal hyperplasia, of course, in addition to other causes in our country, including sepsis. So this baby had to be managed with hydrocortisone at 20 milligram per meter square per day in 3 divided doses. The doses can go as much as 100 milligrams per meter square per day in the initial phase. And at a later stage, the baby was added with fluorocortisone up to 0.05 to 0.2 milligram per meter square per day. The baby was also managed with appropriate electrolyte supplementation, including sodium supplementation and potassium chelators. In the initial phase, often they are managed with insulin dextrose drip. We may have to sometimes use beta-2 agonist nebulizations as well. And calcium can immediately stabilize the myocardial membrane so as to prevent arrhythmias. But in the long-term management, potassium chelators play an important role. So these case scenarios illustrate different types or different different clinical scenarios in which we may be managing neonatal shock, and they can be of different etiologies. So ultimately, what exactly is meant by the term shock? We know it's an acute complex state of circulatory dysfunction where there is insufficient delivery of oxygen as well as nutrients to meet the tissue requirements. We all know the basic rule that blood pressure is equivalent to the cardiac output or the blood flow into the systemic vascular resistance. So in other words, we can put cardiac output on one side of the equation, and we can define that as blood pressure divided by the systemic vascular resistance as well. So blood pressure is the sum total of the cardiac output, which in turn depends upon the product of the heart rate and the stroke volume and the systemic vascular resistance. So cardiac output is equal to the product of heart rate and stroke volume. Now, heart rate can be affected in conditions as we discussed. When there is arrhythmia, there can be myocardial dysfunction in a tachyarrhythmia, or sometimes even with a bradyarrhythmia, the baby can have effectively a reduction in the cardiac output. Sometimes stroke volume may be the culprit, and stroke volume can be affected if there is a problem in the preload, in the contractility, or in the afterload. Now, preload, as defined in the Frank-Starling law, represents or is one of the important factors that determines the stroke volume. Preload can be reduced when the baby has hypovolemia, or if there is diastolic dysfunction leading to impaired left ventricular filling and hence impaired preload and hence impaired cardiac output also. And contractility can be affected if there is myocardial dysfunction, which results in poor contractility manifested by a hyperdynamic precordium. And afterload can be affected if there is an abnormality in the systemic in the vascular resistance. If there is, it can be either high or low. So high afterload is the same as increased systemic vascular resistance, and low afterload is same as peripheral vasodilatation or decreased systemic vascular resistance. Now, the SVR is controlled by hormonal neuroendocrine factors as well as paracrine regulatory mechanisms. So again, this slide, thanks to Dr. Venkat Kalam for this slide, again represents the same concept. So we know that the cardiac output is the product of the heart rate as well as the stroke volume, and stroke volume is determined by these three factors as we discussed. Now, effectively, the cardiac output again subserves the function of delivering oxygen only when the oxygen content of the blood is normal, and oxygen content in turn is decided by the hemoglobin level as well as oxygen saturations. So hemoglobin is necessary for carrying oxygen to all the tissues, and thereby in a baby who is anemic, even if cardiac output is normal or sometimes it is increased in compensation, effective oxygen delivery to the tissues can be poor. Likewise, if there is a significant pulmonary parenchymal problem leading to impaired gas exchange or a VQ mismatch, oxygen saturations can decline. Effectively, again, this leads to poor oxygen content of the blood and poor oxygen delivery. So effectively, cardiac output into the systemic vascular resistance gives us the blood pressure. So all these individual factors can be affected in some disease states, and this can effectively impair the net product, the blood pressure. So we have conditions where the vascular resistance is at fault, where there can be excessive vascular dilatation, as we saw in sepsis or NEC and systemic inflammatory response syndrome. Or there can be a problem by enlargement of the effective vascular bed. So when there is a large hemodynamically significant PDA and a left to right shunt, the vascular bed becomes now effectively much more larger. That effectively it results in a low vascular resistance kind of scenario, or in a large AV malformation, which is also shunting blood from systemic to the venous side, from the arterial to the venous side. Likewise, myocardial contractility can be the issue in various conditions where there is significant myocardial injury, like in birth asphyxia or a postnatal hypoxia, or it may be abnormal in Al-Kappa, where there is anomalous origin of the left coronary artery from the pulmonary artery. It may be involved in cardiomyopathy, either post-viral or post-metabolic conditions, where there may be things like thiamine, beriberi cardiomyopathy, or secondary to drugs. There can be also myocardial dysfunction associated with other conditions, like sepsis itself causes significant myocardial dysfunction, or post-PDA ligation, where there is an abrupt increase in the systemic vascular resistance, hypoplastic left heart syndrome, or prolonged tachyarrhythmia. Abnormal reduced preload can be a problem when there is impaired filling, like in hypovolemia, or in impaired diastolic performance, as in hypertrophic obstructive cardiomyopathy or cardiac tamponade or intention pneumothorax. So these conditions prevent the complete expansion of the left ventricle, leading to impaired LV filling or diastolic dysfunction. Or in low pulmonary blood flow conditions, like secondary to increased mean airway pressure or obstructive pulmonary veins. Increased afterload leading to decreased contractility can sometimes be seen in ELBW babies with failed adaptation in the first 24 hours, when there is a sudden removal of the placenta, which was the low resistance circuit, and this is replaced by the high resistance systemic vessels and post-PDA ligation, or with the excessive use of exogenous vasopressors, or in the cold phase of septic shock. We saw that cardiac output is a product of heart rate and stroke volume. Now, heart rate can be abnormal when there is either persistent bradycardia or persistent tachycardia. Persistent bradycardia as seen in congenital heart blocks, persistent tachycardia as seen in tachyarrhythmias, commonly supraventricular tachycardia and atrial flutter. So now, how do we detect shock? Detection of shock comes from the combination of clinical and echocardiographic parameters. Commonly used clinical parameters. Now, we must remember that the identification of shock requires the sum total of various clinical factors. One isolated clinical parameter is seldom useful for the identification of shock totally, because each of them can be confounded by variable factors. So these clinical parameters include heart rate, the presence of blood pressure, urine output, lactate, capillary refill time. In some special scenarios, hepatomegaly and new onset crepitation, sensorium of the baby. And then this is associated with some lab evidence of abnormal pH, base excess, lactate, and mixed venous saturations. Now, as I told you, each of the clinical parameters can be confounded by a lot of factors. For example, color can be subjective and can be influenced by the lighting, by the hemoglobin the baby has, and by racial factors. Capillary refill time, in turn, although the normal is less than 3 seconds, may also be delayed in hypothermia, not only in shock, but also in hypothermia. Sometimes in hyperviscosity conditions like polycythemia, also the peripheral perfusion may be poor, and we may see abnormal CRT. Likewise, the core to periphery temperature difference, which should be normally below 2 degrees Celsius, can also be influenced by hypothermia and the use of vasoactive drugs. Heart rate, tachycardia is a good marker of shock, but can also be confounded by other variables like the presence of fever, anemia, excessive agitation, pain, and high temperature, hyperthermia. It may go up with some drugs like aminophylline, arrhythmias, and it influences the cardiac output. Blood pressure is often affected in the final or late stages of shock and can be a marker of decompensated shock only. Urine output again is a late marker, and it indicates the renal perfusion. Often this can be complicated by the fact that preterm babies have tubular immaturity, and hence urine output may be falsely preserved, usually in the early phases of shock. So no one clinical sign is reliable. A combination of various signs is what is more useful. So in addition to these clinical parameters, we take the use of some gadgets to assess shock. Now in the pulse oximeter, apart from the heart rate and saturation, one can look at the perfusion index and the pleth variability index. Perfusion index, there are a lot of studies to indicate the utility of perfusion index as an early marker for shock. In echocardiography, which we'll be discussing in a while, there are markers to indicate the adequacy of preload, contractility, as well as the systemic perfusion per se. For preload, we often look at IVC collapsibility as well as the effective LV volume. So if the LV is looking very small and the IVC is small in caliber as well as easily collapsible with respiration, it indicates the presence of relative underfilling or hypovolemia. Contractility of the myocardium is often assessed by eyeballing. Most of the times, eyeballing itself gives some idea, but there are objective measures in the form of fractional shortening and ejection fraction. And when it comes to the effective measurement of cardiac output, left ventricular output as measured by the product of the aortic root diameter times velocity time integral, and right ventricular outflow, which is measured less often, as well as SVC flow are used. There are more advanced techniques of measurement of or detection of shock in the form of near infrared spectroscopy, etc., which are still not very widely used in clinical settings. So this is how the IVC caliber and the variation with respiration can be used for effective assessment of the intravascular volume status. So if the IVC diameter is less than 8 mm, and it is also more than 50% collapsible with respiration, so it often indicates fluid responsive state of intravascular hypovolemia. If the diameter is less, but it doesn't collapse too much with respiration, the collapsibility is only less than 50%, it may indicate that there is scope for giving some fluid, but the full fluid status is not very low. So it's at low normal level. Diameter of more than 8 with less than 50% collapsibility is usually taken as normal, whereas diameter of IVC more than 8 and if there is no variation with respiration, this is usually indicative of high intravascular volume, increased intravascular volume, as can be seen with high pulmonary artery pressures or right ventricular failure or hypervolemia. Now, for measuring the contractility, there are different objective ways in addition to eyeballing itself. So one of the common measures used is the fractional shortening using M-mode echocardiography at the level of the left ventricle in long axis parasternal view. So fractional shortening is calculated by the difference of left ventricular end diastolic dimension and the left ventricular end systolic dimension divided by the maximum dimension, which is end diastolic dimension multiplied by 100. So usually newborns, fractional shortening must be at least 25 to 50%. So if it's below 25%, it's usually indicative of myocardial dysfunction. So effectively, all these parameters, some conventional clinical parameters like heart rate, blood pressure, capillary refill time, pulse volume. So these tests, some lab markers like hemoglobin, base excess, lactate levels, these markers from the lab, and some echocardiographic markers which indicate the volume status, the preload, the myocardial contractility, as well as the left ventricular output. So the cardiac output as indicated by LVO or SVC flow. In addition to this, the overall assessment of the baby, including the underlying clinical scenario. So in a nutshell, this overall assessment is what helps us to detect shock. No single parameter can be useful or cannot be independently adequate for identification of shock. So this is a relatively old study from 2004, Osborne's study, which looked at various clinical parameters. And as you can see, most of the clinical parameters using mean blood pressure as a cutoff less than 30 millimeters of mercury, or mean blood pressure which is less than gestational age in weeks. These are all rules of the thumb. All these cutoffs, or using CRT as cutoff more than 3 seconds or more than 4 seconds, difference between central to peripheral temperature. All these parameters came with relatively low sensitivity and specificity. None of them were found to be extremely useful for the identification of shock in unison. But when all of them were put together, they had a reasonably good sensitivity and diagnostic utility for picking up shock. So we've discussed about the causes, pathophysiology, and the identification of shock. Now we'll move on to the discussion on management of shock. So management of shock always includes overall correction of hemoglobin, which is effectively useful for oxygen delivery, and then reducing the work of breathing by giving the baby optimal respiratory support. Usually for a baby with significant hemodynamic instability, mechanical ventilation is preferable over CPAP. Correcting comorbidities like hypoglycemia, hypocalcemia, and metabolic acidosis, and then the optimal use of fluid replacement, vasoactive drugs, hydrocortisone, and prostaglandin in some special scenarios. Fluid resuscitation remains the mainstay of patients, newborns with septic shock. But as we discussed, in newborns, one has to take this decision carefully because isolated hypovolemia is very, very uncommon. Marked hypovolemia can particularly result in septic shock because of a combination of vasodilatation and increased capillary leak. So there is effectively increased vascular bed, but there is also increased capillary leak. So this can make hypovolemia worse in septic shock. But there has to be a word of caution, particularly in preterm neonates, where there is an increased risk of developing PDA, HSPDA, and intraventricular bleed with hypervolemia. So this was a study that compared the use of crystalloid versus colloid as the fluid replacement of choice in newborns with septic shock. And what did the study show? It showed that there was no difference between the use of 5% albumin or colloid versus crystalloid or normal saline in managing newborns with hypotension, preterm infants with hypotension. Both these solutions resulted in comparable mean blood pressure. But when the use of colloids was associated with higher need for respiratory support, as you can see in the second graph here, the need for the MAP into FiO2 product was much higher with the use of colloids. So it shows that crystalloids are as effective as colloids in the management of shock, but the use of colloids can result in more adversely impacted respiratory dynamics, and hence we can prefer to actually avoid them. So isotonic saline is the preferred crystalloid of choice in the management of shock. For fluid replacement, usually we use a dose of 10 ml per kg over 30 to 60 minutes. Sometimes a dose of 20 ml per kg can be used if the newborn is likely having hypovolemic shock only, or after the 10 ml per kg fluid bolus, one is able to quickly assess the intravascular volume and find persistent evidence of hypovolemia. But we must remember to concurrently correct acidosis if present, hypoglycemia and hypocalcemia before we embark on vasoactive drugs. Now coming to vasoactive drugs, the commonly used agents are listed on the left side. So these act on to one or more of the receptors, the alpha 1 and 2, beta 1 and 2, and dopaminergic receptors. Now, when we take each of them one by one, we see that dopamine, for example, one of the commonly used inotropic agents, has acts on the dopaminergic receptors, the beta receptors, as well as the alpha receptors. So the effect on dopaminergic receptors comes in at relatively lower doses, and this results in renal mesenteric vasodilatation predominantly. The action via the beta receptors comes in intermediary doses of dopamine, and this mediates some increase in inotropy and chronotropy, so increased heart rate, contractility, and this effect can be profound at the intermediary doses, whereas in higher doses of dopamine, at doses beyond 10 mics per kg per minute, the alpha action is predominant, which results in some increase in contractility. But alpha-2 action, which may sometimes dominate in relatively immature infants, can result in significant peripheral vasoconstriction to the point of impairing tissue perfusion. Dobutamine, on the other hand, has predominant action on the beta receptors and is useful for increasing both the contractility as well as causing some peripheral vasodilatation. So this is an inodilator again. Epinephrine or adrenaline is a vasoactive drug that acts on both alpha 1, 2 and beta 1 and 2 receptors, and it causes not only increase in the contractility, increase in heart rate, but it can have variable effect on the systemic vascular resistance. At relatively low doses can cause predominantly beta 2 mediated vasodilatation, but at doses beyond 0.3, 0.4 mics per kg per minute, adrenaline causes more and more vasoconstriction and increased systemic vascular resistance. Is often used in PPHN and cardiogenic shock, and this can have predominant action on the alpha 1 and alpha 2 receptors. So mostly it increases the systemic vascular resistance, and through some beta 1 mediated action also improves the myocardial contractility. A word of caution is that in neonates at lower gestational ages, the alpha-adrenergic receptors dominate, particularly the alpha-2 over alpha-1. So there can be profound peripheral vasoconstriction. In later gestational age, there can be activation of the beta receptors. So this can lead to variable action of the inotropes on the systemic vascular resistance. So as we discussed, lower doses dopamine predominantly mediates renal and mesenteric vasodilatation, increasing GFR to some extent, although low dose dopamine is as of now not recommended by scientific literature. Medium doses, it causes positive inotropy and chronotropy, whereas at doses beyond, usually beyond 10 mics per kg per minute, the alpha receptor mediated vasoconstriction predominates the action of dopamine. Dobutamine, on the other hand, acts via the positive isomer, has effects predominantly on the beta 1 and beta 2 receptors, causing increase in contractility and either no effect or an effective decrease in the systemic vascular resistance, peripheral vasodilatation. Epinephrine has almost a combination of all these actions and can have varied action on the vascular resistance, as we discussed. One study from PGI particularly showed that early use of epinephrine over dopamine was found to be useful in, especially in newborns who are born below or equal to 30 plus 6 weeks of gestational age. And a lot of units are now moving more and more towards the early use of epinephrine in neonatal shock. Norepinephrine, as we discussed, predominantly has the vasoconstriction effect mediated by alpha receptors and has some minimal inotropic and chronotropic effect mediated by beta receptors. Milrinone, which is the most important lucitropic agent that we have, is a phosphodiesterase inhibitor. It exerts its cardiovascular effects through inhibition of cyclic AMP degradation and enhances myocardial contractility as well as promotes myocardial relaxation. So this is the one inotrope that promotes myocardial relaxation during diastole, and hence improves myocardial blood supply, because we know that coronaries perfuse the heart during the diastolic phase. The only flip side of milrinone is that it can cause significant diastolic hypotension because of the lowering of the systemic vascular resistance, usually used at doses of 0.25 to 1 mics per kg per minute. Vasopressin is an endogenous neuropeptide which is produced from the posterior pituitary. Vasopressin, which acts via the V1 and V2 predominantly through the V1A receptors, agonism can cause significant vasoconstriction, increase in systemic vascular resistance, and increase in the blood pressures. It can, as a side effect, cause fluid retention and hyponatremia. The dosing range is to be used between 0.0002 to 0.005 unit per kg per minute. This is an excellent choice in newborns with significant catecholamine resistant hypotension, but it has minimal or no inotropic action. It has not much effect on improving the myocardial contractility. It merely increases the blood pressure. However, it can also lower the pulmonary vascular resistance to some extent and hence can be useful in newborns with PPH. So this is a summary of whatever we have discussed so far. Dopamine, which predominantly acts on dopaminergic, beta followed by alpha agonist action at 2 to 20 mics per kg per minute. Dobutamine, we saw predominantly acts via the beta 1 and beta 2 receptors, and some alpha action increases heart rate, myocardial contractility, and stroke volume, and reduces the systemic vascular resistance. Again, the dose range is 5 to 20 mics per kg per minute. Epinephrine acts on all the receptors, 0.05 to 1 mics per kg per minute. Norepinephrine, predominantly alpha and some beta 1 action, 0.02 to 1 mics per kg per minute. Levosimendan is a calcium sensitizing drug which activates the sarcolemmal potassium sensitive ATP channel at the smooth muscle level, and this helps by increasing the cardiac index, cardiac output, and sensitizes the myocardium to the action of the inotropes. The dosing range is typically 0.1 to 0.2 mics per kg per minute. So this figure actually summarizes the action of the various inotrope drugs. This is actually an often used figure that is easily available. You can see the action in terms of increasing effect on myocardial contractility in the vertical column. So the drugs that are situated on the upper side of the picture have more and more action on enhancing myocardial contractility. And we can appreciate vasopressin and phenylephrine barely influence the myocardial contractility. The drugs on the left increase the systemic vascular resistance through vasoconstriction, whereas the drugs on the right have peripheral vasodilatory effect. Now, finally, in drug-resistant hypotension, especially in preterm population, there is a role of hydrocortisone. So this drug works by multiple mechanisms, by sensitizing the cells to the actions of inotropes, and by increasing the rate of alpha and beta adrenoreceptor adenylate cyclase gene transcription. So it kind of enhances the sensitization of the cells to the actions of the catecholamines. At a shock dose, it is used at a 25 times higher dose than the stress dose, at around 2 mg per kg per dose, 6 to 8 hourly. Every unit should have its own dosing guide with a standard format for calculating the infusions. So in our unit, we typically multiply the baby's weight into 15 times to round off the number 14.4 into 15 times. When we calculate the infusion rates for dopamine, 15 times the baby's weight mixed to make 24 ml of the infusion. So if this runs at 1 ml per hour, typically we will be delivering 10 mics per kg per minute. In a baby who is having volume restriction issues, instead of 15, we can double it and use 30 times the birth weight multiplied into the 30 times the baby's weight taken in 24 ml of the infusate and given at 1 ml per hour will give 20 mics per kg per minute. Likewise, for adrenaline and norepinephrine, the multiplication factor is usually 1.5 times of the weight, and this can be mixed to make 24 ml of the solution. And if it is run at 1 ml per hour, we will be giving 1 mic per kg per minute. So finally, summarizing an algorithm for the management of shock. The endpoints are achieving normal heart rate, normal capillary refill time and blood pressure, and to restore normal perfusion, the difference of mean arterial pressure minus the CVP, and to also achieve pre-rectal post-rectal saturation difference, which is below 5%. And if you are able to measure the mixed venous saturation level, the mixed venous saturation must at least be more than 70%. So this is an algorithm for management of a newborn who is acutely presenting to us with shock. Within the first 5 minutes, it is important to stabilize the newborn's airway, establish a venous axis, push 10 ml per kg of isotonic crystalloid. Maximum used can be up to 20 ml per kg, usually in newborns. We generally don't reach volumes of 40 ml per kg, and we also generally do not use colloids. Correct concurrent hypoglycemia and hypocalcemia, begin the first dose of antibiotics. And if there is a strong suspicion of a duct-dependent critical heart disease like diminished lower limb pulses when compared to upper limb pulses, begin prostaglandin infusion. In fluid refractory shock, we either can start with dopamine or directly prefer to use epinephrine. Usually the dose is started, if it's dopamine, 10 mics per kg per minute and titrated upwards. Epinephrine, we may begin with 0.2, 0.3 mics per kg per minute and titrate upwards based on the response in terms of perfusion and blood pressures. Dobutamine can be added if the baby has manifestations of poor peripheral perfusion in the form of cold, clammy peripheries, prolonged CRT, and increased center to periphery temperature difference. If shock is fluid refractory, dopamine resistant, definitely epinephrine is added at this stage. Further classification or management would depend upon whether the baby classifies into cold shock or warm shock, or a combination of poor function with poor perfusion. So in typical cold shock, the baby could have normal blood pressure with poor LV function, poor myocardial function. Here, the preferred drugs would be inodilators like milrinone or dobutamine. And in cases where, despite this, the systemic vascular resistance is very, very poor, one could even consider adding a nitrosovasodilator like sodium nitroprusside with volume loading. In cases of low blood pressure with warm shock, where the perfusion is relatively normal, pulses are bounding, CRTs flash, but blood pressures are low, one could add a vasopressor along with volume titration in the form of norepinephrine or vasopressin, trying to target adequate normal blood pressures above 5th centile and mixed venous saturation more than 70%. And in a condition where there is both hypotension, poor cardiac function, low blood pressures, then one needs to use a combination approach using epinephrine drip. And if there is severe PPHN, one could use inhaled nitric oxide. And in cases which are refractory to all these medications, after optimizing the pH, after optimizing volume status, hemoglobin, calcium, and glucose, then we may have to even think of ECMO. So coming to the summary of management in these above cases, in the first case of hypoxic ischemia, where we know the problem is combination of cardiac dysfunction with PPHN, management typically involves limiting the fluid boluses probably to 1, not more than 1, using a positive inotropic agent to improve the myocardial performance like dobutamine or milrinone. And if it is associated with poor blood pressure, we could add epinephrine also. And if there is a restrictive ductus with significant PPHN, one could also consider prostaglandin. Hydrocortisone, if shock is refractory, blood pressures are not improving with above measures, and if there is PPHN indicated by oxygenation index which is more than 15 to 20, we could think of a selective pulmonary vasodilator, which is inhaled nitric oxide. In the case 2, extremely preterm newborn with a abnormal transitional circulation, the complicating factors are large PDA with LV, both systolic and diastolic dysfunction. Here, it's very useful to use dobutamine or milrinone to actually reduce the increased systemic vascular resistance and to improve the myocardial contractility. PDA will need to be managed based on the clinical and echocardiographic assessment with cyclooxygenase inhibitors or paracetamol. If blood pressures are persistently low, we think of positive inotropic drugs and hydrocortisone. In PPHN, which is associated with cardiogenic shock, there is not only low left ventricular preload, but there is also right to left shunt and both left ventricular, right ventricular systolic dysfunction. This is managed with optimal ventilatory management, with good lung recruitment, establishing functional residual capacity, correcting factors like acidosis, hypoglycemia, hypocalcemia. Judicious use of pulmonary vasodilators, nitric oxide with sildenafil, with careful monitoring of the blood pressures, inodilators to improve the myocardial performance, titrated with vasopressors to maintain the blood pressure, vasopressin or norepinephrine. When in combination with milrinone, they work very well in PPHN. And in a case of congenital critical heart disease, where there is LV dysfunction, systemic hypertension with associated PPHN, one needs to correct acidosis aggressively, use inodilators to support the myocardial function, prostaglandin if there is a restrictive ductus. Lasix can also help if there is hepatomegaly and evidence of congestive cardiac failure, and adrenaline for low blood pressures. In post-PDA ligation syndrome, where there is sudden increase in systemic vascular resistance and LV dysfunction in preterm newborns post-PDA ligation, one needs to optimize ventilation, use inodilators. Milrinone is very, very useful in post-PDA ligation syndrome associated shock, and hydrocortisone for adrenal insufficiency. So the take-home messages for the talk are: shock is a failure to meet the tissue oxygen demand by the baby's cardiac output. And it is important for us to understand the level at which the hemodynamics went abnormal, which is key to management. Clinical indicators, single clinical indicator is never completely reliable, and a combination of signs is very useful. Echo often helps us to optimize the treatment, and supportive care is very mandatory and useful for all these cases. And we should titrate the cardiac medications based on the condition. So with this, I will go into the unit. We shall be discussing some useful echocardiographic parameters for the assessment. So before I come to the echocardiographic parameters, Okay. So before we move on to the clinical, to the echocardiographic parameters. So some useful clinical parameters in a baby who is in shock are, you can see the heart rate here. So heart rate is within normal limits. Anything more than 160 is taken as tachycardia. We would also be able to see here is the perfusion index. This is 1.1 in this baby, quite normal. Anything below 0.7 or 0.8 is often considered as abnormal. When it comes to clinical parameters, I'm wearing a glove for the purpose of echocardiography. We assess the pulse volume. Pulse volume, which can be assessed at various points. And capillary refill time, typically we measure this over the sternum for 5 seconds and we assess the refill. Okay. Blood pressure is an important indicator. Are we now visible? So just follow the instruction. So I will repeat again the clinical assessment of shock. So it begins with heart rate. So heart rate is here. This heart rate is now well within the normal limits. It is between 100 to 180 per minute. And while on the pulse oximeter, you can also look at the perfusion index. So you can see this here. Now it is 1.1. So in this baby, there is a difference between pre-rectal as well as the post-rectal saturation. So this is indicative of PPHN. The other clinical parameters are the measurement of pulse volume. So you can look at the brachial pulse and the lower limb. So we are going to assess the posterior tibial pulses. So in a baby with coarctation, there will be a difference within between the upper limb and the lower limb pulses. Capillary refill time in a newborn is always assessed at the sternum. So 5 seconds, release. 1, 2, 3, 4, 5, 1001, 1002, 1003. So in this baby, it's less than 3 seconds. So this shows that the CFT is within normal limits. Coming to the assessment of the non-invasive blood pressure. So NIBP versus IBP. NIBP always over-assesses the blood pressure or overestimates it by around 3 to 5 millimeters of mercury. For assessing NIBP, which uses the oscillometric technique, the first thing is to choose the adequate size of the blood pressure cuff. So you will see branded blood pressure cuffs from different companies. This is from Philips. So every cuff will mention the the range of circumferences of the arm across which it can be used. So the important here thing is to choose the appropriate size of the bladder within this cuff. When we choose the cuff, one should make sure that it should encircle at least 2/3 of the length of the baby's arm from the acromion of the shoulder to the olecranon, to the process here, olecranon process. And in terms of circumference, it should entirely encircle the baby's arm. So let us now measure the blood pressure from the leg. So then we can just press the start button here for inflation of the cuff, and then automatically the blood pressure will be observed, will be measured. So these are all some clinical markers. In the pulse oximeter, we can look at perfusion index. Some pulse oximeters will also give us pleth variability index. Now, having measured, seen the heart rate, pulse volume, CRT, the center to periphery temperature difference can be measured by placing this temperature thermistor probe in the sternum as well as over the peripheries. So if we get a difference of more than 2 degrees Celsius, again, it's indicative of poor peripheral perfusion. So in addition to these parameters, the lab parameters are the measurement of pH in the blood gas, base excess more than -6 is abnormal, elevated lactate more than 3.5 millimoles, micromoles per liter is abnormal, and mixed venous saturations when we take blood gas from a neck vein from the SPC. That is again going to be useful for us. So in addition, how does echocardiography help us? We have already had 2 sessions by Dr. Subir and by Dr. Pranita. So today we shall be only discussing about some relevant aspects with regards to shock. So coming first, we discussed about preload. So preload, how can we assess? So we assess by the IVC contractility, IVC collapsibility and IVC diameter. So keep the probe. So first position of the probe is in the subcostal view with the probe pointing towards 12 o'clock position. So this is the probe. This must be pointing towards 12 o'clock position and you place it in the subcostal view. So when you do this, we'll be able to see the IVC when you sweep slightly to the right. So this is the IVC for the baby. IVC, this is entering the right atrium. So we can see the IVC is kind of fairly wide. It is not very small or contracted. So using this view, we can kind of freeze. So we can measure the size of the IVC using the calipers. So this says around 4.9 mm, around 5 mm. Okay, so anything which is up to 6 to 8 mm is generally taken as acceptable. More than 8 mm, we say that the IVC is already very congested. And we also look at not only the absolute size of the IVC, but also the collapsibility of the IVC with respiration. So this IVC actually looks quite fairly congested only. And if you see, it's not varying too much with respiration. So if the variation with respiration is less than 5%, it is said to be that IVC is not collapsible. If the collapsibility is more than 50% or more than 50% with respiration, then it indicates that there is scope for giving more fluid. So if IVC caliber is more than 8 mm and less than 50% collapsibility with respiration, then it's fairly indicative of hypervolemia. Either hypervolemia or there could be RV dysfunction, there could be severe PAH, all these, or a cardiac tamponade, all these can lead to IVC congestion. The other area from which we also get an assessment of the volume. So this is a apical 4-chamber view. So this is kind of an inverted view. These are the 2 atria, and this is the right atria and the right ventricle, left atria and the left ventricle. So if there is significant hypovolemia, we'll also see that the LV chamber is kind of contracted and narrow. Although it looks relatively smaller than RV, here the problem is not hypovolemia because we have seen how congested the IVC is. Now, the next important aspect that we want to know from the echo is the myocardial performance. So this is very often accessible with eyeballing. Eyeballing is a subjective assessment of myocardial contractility by looking at the chambers. So in this 4-chamber view, we can fairly see that the contractility is good. The LV as well as the RV do look hypertrophic, but the chambers are contracting fairly well. So on eyeballing, the contractility of the myocardium looks fairly okay. An objective assessment of contractility can be measured by looking at the fractional shortening we discussed. So for we'll just look at the view. For assessing fractional shortening, we must get a long axis parasternal view. So you keep your probe along the axis of the baby's heart, and the probe must be pointing towards the 1 o'clock position or the right shoulder. So in this view, now we can come to the machine. You get a, yeah, so that's a long axis parasternal view. So here, this is the left atrium to LV. This is the mitral valve, LV to aorta. This is the aortic valve, the aorta, and above on the anterior aspect, we see the right ventricle actually here. So we can again make sure, we can again see on eyeballing that the function is fairly good. Now, in order to measure the fractional shortening, we'll have to press M mode. So we place the M mode line aligned to the LV. Yeah, we'll freeze it. Once. So here, so in order to measure the fractional shortening, we'll have to choose the calculations where we will get EF. So this is the left ventricular diastolic dimension, left ventricular systolic dimension. So we first select the diastolic dimension and we can choose the widest part of the left ventricular cavity. So let's take this part of the cavity in diastole. So we select it here, and likewise we select the lower part of the LV. This is the dimension during diastole. We'll have to physically remember this because it's not calculating now. It's 1.14 centimeters. And during systole, let's say here, it's actually quite narrow. It's 0.57. And we'll have to save calculator. So 1.1 minus 0.5 divided by 1.1. So it would come to almost, it's coming to calculated EF of 82%, which is fairly acceptable. So these are the two techniques for looking at the myocardial performance. So one is the eyeballing on the apical 4-chamber view. So we're actually getting a good ductal view now. So this is the apical 4-chamber, and then we move on to left axis parasternal view. So that's left axis parasternal view where you get the ejection, the fractional shortening. Now, other things to assess, particularly in a preterm baby, are the presence of a duct. As you can see here in the 2D view, there is a classical tripod view that we can see. This is the aorta, Mercedes-Benz sign, and we can see the branching of the RPA, the left PA, and the last vessel is the ductus. So if we put a color there, we will be able to see a red jet. If there is some degree of left to right shunt, we should be able to see the red jet, which will be the flow of blood towards the probe. So this is a summary of what all we can do in the echo for assessment of the intravascular volume by looking at the IVC volume, collapsibility of respiration, myocardial performance by eyeballing as well as the fractional shortening. Thirdly, the presence of complicating PDA, which you can appreciate here. We can further Doppler the PDA actually. Once we have identified the PDA, so if we place the Doppler in PDA, so we can appreciate that this is a bidirectional shunting PDA. So you can see that there is both shunt, which is left to right. This is aorta to pulmonary artery, which is represented above the line, and this is pulmonary artery to aorta, which is represented below the line. Likewise, the presence of significant pulmonary hypertension can be assessed by looking at the presence of tricuspid regurgitation in the apical fourth chamber view. So we can already appreciate that the RA and the RV are quite hugely dilated. And if we further Doppler the tricuspid valve, we must be able to see presence of significant tricuspid regurgitation. The other marker for can we invert this? When we look at assessment of diastolic function, the presence of mitral EA ratios is quite useful. We have just inverted the view here. So here again we have inverted the view now, atria, ventricle, right side, left side. So if we take Doppler at the level of the mitral valve, yeah, we'll be able to see the E by A ratios. So the first peak is the E and the second peak, so it's sort of clear here, E and the A. So generally E is the flow caused because of the passive filling of the ventricle from the atrium, whereas A is because of atrial systole. So the atria contracts and pushes blood into the ventricle. In E, there is passive filling from the ventricle to atrium. Normally, passive filling predominates over the atrial systole-mediated filling in adults and in bigger children. But in preterm newborns, very often this ratio might be reversed because of diastolic dysfunction. So there may be a more and more dependence on the atrial contractility for the filling of the ventricle. Hence, the A wave may be actually predominant over the E wave. So the assessment of the E by A ratio can actually help us in determining whether there is diastolic dysfunction or not. So that we assess by getting a apical fourth chamber view and by looking at the mitral valve Doppler. So these are all some of the things that we can use in the echo. So thank you all for joining us. Wow, Jesus.